A very pleasant evening to one and all who have joined us today. From today, we are starting the NEET PG Rapid Revision session. And to start the series, we have our most respected Dr. Rashmi Shivram ma'am, Faculty of Medicine, Medusane. We welcome you, ma'am. We'll be having 2 days of a NEET PG Rapid Revision for General Medicine. I hand over the session to you, ma'am.
Very good evening to all of you. So I'm very happy to be back with this, rapid revision for NEET PG for the subject of medicine. So this is basically based as a rapid revision. So we'll just be going a little fast, and all the important topics which are likely to be questioned every year, which are basically repeat topics. So what happens is the repeat questions are basically because the concepts are repeated, but the questions will be slightly different. So we'll see one question and what all are the MCQs which can be taken from that. What are all the other MCQs which can be taken from that is what we will be discussing in this. Okay, so I have taken 2 days for this. So the first day, that is today, we will be discussing all the image-based questions. Okay, and then tomorrow we'll be having the question discussions. Okay, so all this we will be discussing today, and then we'll be discussing the questions tomorrow. Okay, yeah. So let us start. The first question, a 65-year-old female is brought to the emergency in an unconscious state. Her BP is 70 by 50 millimeters mercury. Her ECG is shown below. What is the next best step in the management of this patient? So, this is a patient who has been brought to the emergency in an unconscious state. Her BP is 70 by 50 millimeters mercury. Her ECG is shown below. So, what is the next best step in the management of this patient? So, is it IV verapamil, IV adenosine, carotid massage, DC cardioversion? So just have a look at this ECG and let me know what will be the first line of management for this patient. Okay, so I would like all of you to answer in the chat box so that we can have a discussion. So here is a 65-year-old lady who is brought to the emergency in an unconscious state. Her BP is 70 by 50 millimeters mercury and her ECG is shown below. So what is the next step in the management? Will you be giving verapamil, adenosine, carotid massage, or a DC cardioversion for this patient? So we'll first look at the ECG. Okay. So when you look at the ECG, what strikes you first? You have tachycardia, right? You have tachycardia. The heart rate is elevated. Yes, Dr. Raghu says it's DC cardioversion. I would also like you to tell me why it is DC cardioversion. So basically, the exercise is going to be like you have to find out what the answer is. And you also have to rule out you have to tell me why you're ruling out the other options. Okay. So the striking thing is you have tachycardia, right? And once we have tachycardia, we need to find out if the RR intervals are regular or not. So we need to find out if the RR intervals are regular or not. So we find that it is regular. So it is a tachycardia with regular RR interval, right? And is the QRS complex narrow or wide? It is a narrow complex. So it is a narrow complex regular tachycardia, right? Regular tachycardia. So this is a paroxysmal VT, right? Paroxysmal supraventricular tachycardia. It is a PSVT, paroxysmal supraventricular tachycardia. So now coming to the question, we now know that this patient is having a PSVT. Yes, supraventricular tachycardia. So when the patient is having a supraventricular tachycardia, so how should we treat this patient? How should we treat this patient? We should see the general condition of the patient. We need to find out if her BP is stable or not, right? We need to find out the hemodynamic stability of this patient. So how do we do this? So first is we have known that the patient is having a PSVT. So we need to find the hemodynamic stability of the patient, whether the patient is stable or not stable. Stable or not stable. If the patient is not stable, what will you do? If the patient is stable, what will you do? So if the patient is stable, first you will try a vagal maneuver, right? First you will try a vagal maneuver. If that also does not work, then what do you mean by vagal maneuver? Basically, we do a carotid massage, right? We do a carotid massage for this patient. If that does not work out, you will give adenosine. we shall be giving adenosine, right? IV adenosine will be given to the patient. So if IV adenosine is not working, then you give a calcium channel blocker, either verapamil or diltiazem, right? We give a verapamil or a diltiazem, or in few patients, you can give a beta blocker, right? So first, if the patient is stable, you give a vagal maneuver, you give an adenosine IV. If the vagal maneuver does not function, then you have to give IV adenosine. If that is also not working out, you can either give verapamil or diltiazem or a beta blocker. If all these things don't work out, you have to again treat like how you're going to treat this unstable patient. So when the patient is not stable, what will you do? You will do a DC cardioversion, right? Dr. Shruti says it's adenosine. So no, because the patient is hemodynamically not stable. The patient is having a BP of 70 by 50 millimeters mercury. So this patient is not hemodynamically stable and she's in an unconscious state. So the patient is unconscious and hemodynamically unstable. So for this patient, the management of choice will be a DC cardioversion, right? The management of choice will be a DC cardioversion. So we'll see something about SVT, right? What are the other questions that can be asked about SVT? So basically, what do you know about SVT, right? What are the types of SVT? There are two types basically. So what are they? It is AVNRT, AV nodal reentrant tachycardia, or AVRT. Okay, atrioventricular reentrant tachycardia. It is AVNRT or AVRT. These are the two types of SVTs that we are aware of. So what happens basically in this SVT? So what happens is, so this is a slow pathway and this is a fast pathway, right? So what happens is, normally an impulse which comes here, when a premature atrial complex comes here, what happens is it is transmitted through both the slow pathways, which goes very slow, and it is also transmitted to the fast pathway. So what happens is, by the time the slow pathway is getting transmitted, the fast pathway gives out an impulse downward, and also it goes and cancels out this slow pathway's impulse, right? So the resultant impulse will be a regular wave. The resultant impulse will be a regular impulse. Okay, so you will have a sinus rhythm. Sinus rhythm. But what happens when there is a refractory period? What do you mean by refractory period? So suppose a muscle has contracted, it will be in refractory period for some time before another impulse can come and act on it for it to generate an impulse, right? For it to generate another impulse, it will be in refractory period. After some time, it will be able to take up the impulses which are coming inwards. Okay, so say this is slow and this is fast. Saying that this fast pathway is in a refractory period right now. Okay, so what happens? Now premature atrial complex is coming here. It will be transmitted to the slow pathway faster and it will be blocked here. So what happens? It will not be passed. So what happens? Then it takes some time. It comes very slowly. It comes like this. Then it tries to go here. By the time this refractory period will be over. So it will again be going like this. It will be going in a circuit. Some impulse will be sent downward, as well as some impulse will be sent again and again as a loop. Okay, it will be a re-entry. It will keep on going like this. Okay, so this is what is called slow fast AVNRT. Slow fast AVNRT. Okay, you get it? So this is called slow fast AVNRT. So there are three things. One is slow fast AVNRT. In this, the P waves will not be visible. P waves will not be visible. This is slow fast AVNRT, right? Next is fast slow AVNRT. What happens in this? In this, we have in the slow fast AVNRT, we have seen that the fast pathway is first initially in refractory period. But if the slow pathway is initially in refractory period, you will get a fast slow AVNRT. In this, the P waves will be after QRS. The P waves will be after QRS complex, right? The P waves will be after QRS complex. So there is one more which is called slow AVNRT. What happens in this? The P waves will be before QRS complex. P waves will be before the QRS complex, right? So now we have seen what is AVNRT and we are now going to see what is AVRT. So you have now understood what are the three types of AVNRT: slow fast AVNRT, fast slow AVNRT, and slow AVNRT. Okay, so what happens in AV reentrant tachycardia? This is atrioventricular, right? So this is because of the accessory pathways. This is because of the accessory pathways. Right. This is because of the accessory pathways. What happens? What are the two types in this? It is orthodromic. It is either orthodromic or antidromic. Right? It is either orthodromic or antidromic. So what happens in this orthodromic? The regular conduction, and you have an anterograde conduction as well as a retrograde conduction. Okay. So what happens? The anterograde conduction is through the AV node. Anterograde conduction is through the AV node. Anterograde conduction is through the AV node. In this, what happens? The anterograde conduction is through the accessory pathway. The anterograde conduction is through the accessory pathway. Okay. So what happens in this? The RP interval will be long. RP interval will be long. So what happens in orthodromic AVRT? You will have a narrow complex tachycardia. You will have a narrow complex tachycardia. Whereas in antidromic, you will have a broad complex tachycardia. You will have a narrow complex, and in anterograde, in antidromic, you will have a broad complex tachycardia. Okay, this is what you need to remember. So in SVT, you have two types, basically AVNRT and AVRT. AVNRT is because of the pathways, the conduction system of the conduction system, which can be either slow and fast, and which one cancels out which one is there in a refractive period. Based on that, you will get a impulse. Okay, so that is called AVNRT. The other one is AVRT, which is the transmission through the accessory pathways. It can either be orthodromic or antidromic. Orthodromic is when the anterograde conduction happens through the AV node. In this, the RP interval will be long and the narrow complex tachycardia will happen. Whereas in antidromic, it will be a broad complex tachycardia because the anterograde conduction happens through the accessory pathway. Okay, is this clear? Yeah. So now I hope you understand. So if a patient is in supraventricular tachycardia in an unstable state, then the patient should be given a cardioversion. Right? Okay. So the next one. Next question. A 40-year-old male patient came to the emergency with complaints of weakness, paresthesia, and breathing difficulty. The following is the ECG of this patient. Which of the following would be the most likely electrolyte abnormality? Okay. So this is a 40-year-old male patient complaining of weakness, paresthesia, and breathing difficulty. What is the most likely electrolyte abnormality? Okay. So let us go through this ECG. What do you think are the findings in this ECG? Please put up your answers in the chat box. So what are the most likely electrolyte abnormalities? First, let us find out what does the ECG say. Right? Yeah. So you have an ST depression, ST depression and T wave inversion. Here also you can see the ST depression is there. There is a T wave inversion as well as an U wave. Yeah, you can see the U waves. Right? Here you can see the U waves as well. So what all you have? You have an ST depression, T wave inversion, and an U wave. Right? All these three characteristically, all of us know it is hypokalemia. These findings are seen in hypokalemia. Right? These findings are hypokalemia. So what happens when the hypokalemia worsens? Yes. Yes, Dr. Himanshu, Dr. Venkatesh, it is hypokalemia. The answer is correct. Okay. So there's one more question I want to lead you on into. So when the hypokalemia worsens, these are the findings when there is a somewhat mild to moderate hypokalemia. When the hypokalemia becomes severe, what is the type of arrhythmia that you will see in the patient? Can anyone tell me what is the arrhythmia that you will see in a patient with severe hypokalemia? What is the type of arrhythmia seen in this patient with severe hypokalemia? Yeah. So what happens is you will start bradycardia. No. You will start having ventricular ectopics. You will start having ventricular ectopics. But in this patient, what will happen is, contrary to what Dr. Venkatesh thinks, it is going to be a tachyarrhythmia, right? It is going to be a tachyarrhythmia. Okay, so you will have supraventricular tachyarrhythmias, and later what will happen is it will predispose the patient to developing torsidis de pointis. Okay, so the patient will develop a VT or a torsidis de pointis. Okay, so contrary to what we believe in hypokalemia, when the hypokalemia becomes more and more severe, the patient will have tachyarrhythmias. Okay, so the patient will have tachyarrhythmias. especially if the patient is having a concomitant hypomagnesemia. Especially if the patient is having a concomitant hypomagnesemia. So what happens is, normally when we see patients with hypokalemia, we find that the magnesium levels are also low, isn't it? So when the patient is having hypokalemia plus a hypomagnesemia, the patient will have an increased predisposition to develop ventricular arrhythmias as well as torsidis de pointis. Okay, I hope it was a good learning point for you, Dr. Venkatesh and others. So hypokalemia, when it is mild to moderate, you will have ST depression, T wave inversion, U waves. Then gradually ventricular ectopics will develop. Then you will have a supraventricular arrhythmias. And then you will have VT or a torsidis de pointis. Okay, so let us now see about other things. What are the other findings in hyperkalemia? So you have seen about hypokalemia. So when they ask about hypokalemia, they can very well ask about hyperkalemia also, right? So what are the findings on ECG in a patient with hyperkalemia? Okay, can anyone tell me what are the one? I will tell you, it is very easy. You will have peaked T waves. Okay, you will have peaked T waves. So what are the other arrhythmias that you will find in this patient? So in hyperkalemia, you will have bradyarrhythmias. So in bradyarrhythmias. So in hyperkalemia, you will have bradyarrhythmias. Yes, Dr. Venkatesh, you will have tall tented T waves, and the final thing will be a sine wave pattern. Right? The patient will have a sine wave pattern. They can also go on to develop PEA or asystole. PEA or asystole. Okay. Gradually, the QRS will keep on widening and it will become a sine wave pattern, and the patient can go into pulseless electrical activity or an asystole. Right. So these are the findings in hyperkalemia. So we've now seen hypokalemia and hyperkalemia. So what is the next one? Hypocalcemia. I'm just concentrating on the common questions which are asked, right? So hypocalcemia, all these questions are asked very regularly, right? In some form or the other, they mention this, right? Hypocalcemia, it's very easy. You will have a QT prolongation, right? You will have a QT prolongation, right? Yes. Then what about Osborne waves? This is again another MCQ which is asked commonly. Osborne waves. So what happens in Osborne waves? Where do you see this? So what is an Osborne wave actually? Osborne waves are basically where the J waves are deviated. Yes, there is a deviation of the J waves. Correct. So Dr. Venkatesh says it's hypothermia. Hypothermia, all of us know. So what are the other conditions in which you get these Osborne waves? One is hypothermia. Next is hypercalcemia. Right? Hypothermia, hypercalcemia, and also tachycardiomyopathy. So what is this tachycardiomyopathy? It is basically some stress-induced myocardial stunning which happens, right? Myocardial stunning will happen. The EF will become very less, but the ECG findings will not be that great. Okay, so this is called tachycardiomyopathy. Commonly in MCQs, they will mention a middle-aged lady who has either lost her husband or who has had a big stressful event, something like that would be mentioned in the question. Leading on to that, they will say that the left ventricular function is very less. So in those patients, but the coronaries are normal, right? But they do a coronary angiogram, they take the patient immediately for a CAG, and they find out that the coronaries are normal. So in those patients, what does it? It is a tachycardiomyopathy, right? It's a tachycardiomyopathy. Yes. So we have now discussed the basic electrolyte abnormalities and the ECG findings. Okay, I hope it's clear. We have discussed about hypokalemia, hyperkalemia, hypocalcemia, and where Osborne waves are seen. Right? Okay. So let's move on to the next question. A patient presents to you with an irregular pulse of 120 per minute with a pulse deficit of 20. The following is the ECG recording of the patient. What would be the JVP finding? Right? What would be the JVP finding? Okay, so let's have a look at this ECG. Yes. So what do you find in the ECG? Canon A wave. So Dr. Venkatesh says it's a Canon A wave. Okay. So Dr. Venkatesh, can you tell me why do you think it's a Canon A wave? We'll just go through the question once again. A patient presents with an irregular pulse. Okay. So as soon as you see irregular pulse, what should strike you? It should be either atrial fibrillation or an AV block. Right. Of 120 per minute with a pulse deficit of 20. The following is an ECG recording of the patient. What would be the JVP finding? right? Dr. Venkatesh says it's AV block. Yes. Yeah. So SR, it is not VT. You can see this is not VT. The QRS complexes are narrow. It's not a VT. So, like he said, like Dr. Venkatesh says, it's atrial fibrillation. The RR intervals are not regular, right? The RR intervals are not regular. It's a tachycardia, narrow complex. There are no P waves. We can't make out the P waves. So, what is it? And the pulse deficit is more than 20, which means it is atrial fibrillation. So, it is atrial fibrillation, right? So, let's move on to what do you find in the JVP. What is the finding of when there is an atrial fibrillation? What do we know commonly? What happens to the A wave in the JVP? A wave will be lost, right? The A wave will be lost. So what are the normal waves in a JVP? So you have an A wave, right? And then you have an X descent, then again a C wave, and then it comes down. Then you have a V wave and a Y descent, right? So 3 upward waves which are A, C, V, and the 2 descents which are X and Y. Okay, so let us now learn why these waves happen. So we say that A wave is lost in AFib. Yes, Dr. Sai and Dr. SR, it is an absent A wave. That's right. So what happens in the A wave? The A wave is because of an atrial contraction. A wave is because of an atrial contraction. So when the atrial contracts, so what is JVP basically? It is a recording of the right atrial pressure in the neck veins. Okay, so it is a recording of the right atrial pressure. So right atrial pressure is reflected when it increases, the JVP will also increase. So when there is a volume overload condition or when there is congestive cardiomegaly, congestive cardiomyopathy, cardiac failure, what will happen is the neck veins will get engorged. That time you will have a JVP which you measure and you will say that so many centimeters of JVP are elevated. So that's what we do. So how do we find out the waves? So A wave is because of atrial contraction, right? A wave is because of atrial contraction. Next, the C wave. C wave is because of ventricular contraction. So basically what happens when there is a contraction, the pressure inside increases, which is shown up as a waveform, right? So ventricular contraction. So these are the 2 conditions where the pressure increases. There is one more condition where the pressure will increase. This is because of the filling, right? Atrial filling. Atrial filling. So what happens? Then there is an atrial contraction, the pressure will increase. When there is a ventricular contraction, the pressure will increase. When there is a venous filling into the atrium, that time also the pressure will increase, right? Because of the stretch, because of that, the pressure will increase. So what about the X and Y descent? When do these happen? The X descent is when the atria relaxes. Atrial relaxation. So the atrium first contracts, then relaxes, then you have the ventricular contraction, then you have in the meantime, the atrium starts filling, and then the Y descent. Y descent is when the tricuspid valve opens. So there is a sudden gush of blood moving from the right atrium into the right ventricle. That time the pressure drops suddenly. So that's why you have a descent. Okay, tricuspid opens. Yeah. So tricuspid opens. Now tricuspid bulge, it's not tricuspid bulge, Dr. Venkatesh. When the tricuspid opens, what happens is there's a sudden drop of pressure because the blood from the right atrium goes into the right ventricle. Right. So there's a sudden drop of pressure. So there is a descent in the JVP. Okay. I hope you understand. Atrial contraction, A wave. C is ventricular contraction. V is atrial venous filling. X descent is because of atrial relaxation. And Y descent is because the tricuspid valve opens. Right. So in AF, what will happen? The A wave will be lost. Tricuspid valve, it will be lost. So what happens? How do you treat atrial fibrillation? Let's see something about atrial fibrillation here itself. So what happens? How do you treat atrial fibrillation? So the primary goal will be for rate control, right? Rate control is the primary goal. We don't want the patient to be in tachycardia persistently, right? Rhythm control comes secondary. The first idea is you should be controlling the rate of the patient. So how will you do that? You can do either beta blocker or you can give esmolol, right? Or verapamil, right? You give the patient a beta blocker or an esmolol or a verapamil. Okay. So what are the rhythm control measures that we are aware of? Rhythm control also we can do, but the primary aim will be to control the rate, right? So what is the rhythm control drugs? Amiodarone, right? Amiodarone is what we give. You can also give ibutylide. You can also give ibutylide. Yes, correct. Rate and rhythm control. Beta blockers, calcium channel blockers. That's right. Dr. Venkatesh, amiodarone is also correct. So, rate control and rhythm control. So, what is the other important thing that you should be remembering in these patients with atrial fibrillation? So, they are very much prone for developing stroke, vascular complications, right? So, they are very prone for developing a stroke. So, what should you do in these patients? You should anticoagulate them. So, you should anticoagulate them so that they don't develop clots. Yes, anticoagulation. So, what is the choice? You can either give Novax, which is usually preferred, or in patients with mitral stenosis, what will you give? You would have to give warfarin, right? You would have to give warfarin. So this anticoagulation is based on what score? You have the CHAD-VAS score, right? CHAD S2 VAS score, right? Yes. CHAD-VAS score, right? I hope all of you know what the CHAD-VAS score is. Yes. 2 you have for age and 2 for S. S1 is prior stroke and the other one is S is sex. Female sex, right? So female sex people have a higher predisposition to develop these complications. So in these patients, you have to anticoagulate them. So what are the NOACs that we are aware of? Dabigatran, rivaroxaban, and apixaban. This is what we commonly use nowadays, right? And warfarin. These are the anticoagulants that we are giving. Okay, so I hope we have answered some questions. So the MCQ can be in AF patients. What is the primary, primary aim of treating the patient? The first one should be rate control. And when do you anticoagulate? It is based on the CHAD-VAS score. And how do you anticoagulate? You can give Novax, which are dabigatran, rivaroxaban, or apixaban. And you can also give the patient warfarin in selected patients, like those who have valvular MS. In those patients, you have to give warfarin, right? We have answered so many questions right now, right? Okay. So we have also seen about JVP. We very commonly, they ask about which wave is caused because of what. I hope you've got a clear understanding of how the JVP is caused, right? Okay. So for the answer for this question will be absent A wave. So Canon A wave will be seen in AV block that we all know, right? And P wave is not seen in JVP. So this is ruled out, right? Okay. So next again is a question on JVP. So evaluation of a patient revealed the presence of a mid-diastolic murmur. The JVP is shown here. What is the likely diagnosis? So you have a mid-diastolic murmur. So when you have a mid-diastolic murmur, what should immediately come to your mind? You should think about the differential diagnosis for a mid-diastolic murmur, right? So let's go through the options once. It's mitral stenosis, tricuspid stenosis, mitral regurgitation, or tricuspid regurgitation. Okay. So you can tell me, yeah. Dr. Venkatesh says it's tricuspid stenosis. So if you can elaborate also, it would be good. So what are the differential diagnoses for a mid-diastolic murmur? That is also an MCQ, right? What are the differential diagnoses for a mid-diastolic murmur? Okay. First, all of us know mitral stenosis, right? It is present on, you can hear it in the apex, more on the left lateral position and heard better with expiration, right? That is mitral stenosis. The next one will be tricuspid stenosis. Tricuspid stenosis is heard on the left sternal border, right? Which is increased on inspiration. So that is tricuspid stenosis. What is the next one? You can have an Austin Flint murmur. Few other murmurs, named murmurs are there. Austin Flint murmur. You can have a Carey-Coombs murmur. Right? You can have a Carey-Coombs murmur. Then if you have a left atrial myxoma, murmur due to left atrial myxoma, or due to a ball valve thrombus, right? Or due to a ball valve thrombus, right? All these produce mid-diastolic murmurs. Okay, this again can be a question. Which of the following is not will not produce a mid-diastolic murmur? That can be a question, right? So we have now seen what are the differential diagnoses for a mid-diastolic murmur. So in this patient, what happens? What do you find on the ECG? I mean, on the JVP. What do you find on the JVP? The finding is the A wave is tall, right? The A wave is big. A wave is more prominent, right? So A wave is prominent. Where is this seen? This is seen in tricuspid stenosis, right? This is seen in tricuspid stenosis. So let us see. So the answer for this question is tricuspid stenosis. I would like all of you to tell me what, we'll discuss the different findings on the JVP. So we saw already absent A wave is seen in atrial fibrillation, right? Then prominent A wave is seen in either tricuspid stenosis or pulmonary stenosis. Okay, pulmonary hypertension or pulmonary hypertension, right? In pulmonary hypertension, you have prominent A wave. Where do you see a Canon A wave? This is commonly asked. Canon A wave, all of you know, it is AV block. Right? Canon A wave is AV block. So I would like you to tell me, when do you find a large V wave, then large C and V wave, large CV wave, right? And where do you see? So this large CV wave will always be associated with a rapid Y descent. This is again a very, very important MCQ, which is asked very commonly. So large CV wave with a rapid Y descent and absent Y wave. Can any of you attempt it? So where do you find a large V wave? Where do you find a large CV wave along with a rapid Y descent? And where do you find an absent Y wave? Okay. So if you want, we can go from down. Absent Y wave is seen in cardiac tamponade. Right? It is seen in cardiac tamponade. Large CV wave with a rapid Y descent. This is a very, very important MCQ. It is constrictive pericarditis. Right? Constrictive pericarditis. They commonly ask this, right? Large CV wave with a rapid Y descent. This is seen in constrictive pericarditis. So where do you find a large V wave? It is very easy. You can find it in tricuspid regurgitation. Okay, tricuspid regurgitation. I want some more interaction. Okay, so absent A wave, atrial fibrillation, prominent A wave, tricuspid stenosis or pulmonary hypertension, Canon A waves in AV block, large V waves in tricuspid regurgitation, large CV wave with a rapid Y descent, constrictive pericarditis, and an absent Y wave, cardiac tamponade. Okay, so I hope this revised JVP completely for you, isn't it? Okay. Let's move on to the next question. Identify the condition based on the murmur depicted below. So you have S1, sorry, this one is S1, this is S2. So what is the murmur which is being depicted here? Is it of mitral stenosis, mitral regurgitation, aortic stenosis, or aortic regurgitation? What is the murmur which is depicted here? Yes, you can try. Is it mitral stenosis, mitral regurgitation, aortic stenosis, or aortic regurgitation? So you can find that the murmur keeps increasing towards the mid and then it decreases towards the S2. Right? It increases and decreases. Right? So what is it? It is a crescendo-decrescendo murmur. Right? It is a crescendo-decrescendo murmur. Okay, it is a crescendo-decrescendo murmur. Okay? Yes. So where is this seen? Where is the crescendo-decrescendo murmur seen? We find it in aortic stenosis. Yes, crescendo and decrescendo murmur. So let us revise about some systolic murmurs. Yeah. So let us see about some systolic murmurs. Where do you find a systolic murmur? What do you find in MR? It is a pan-systolic murmur. So how will it be? In the same recording, it will be throughout, right? Throughout from S1 to S2, you will have a pan-systolic murmur. That is in mitral regurgitation. In aortic stenosis or HOCM, you have a crescendo-decrescendo murmur. In mitral valve prolapse, what you have? You will have a mid-systolic click, right? You will have a mid-systolic click. Along with that, you will have a late systolic murmur, right? Late systolic murmur. So how will it be? You have S1 and S2. So you have, it goes on like this. Here you have a mid-systolic click and then you have a murmur. So this is an MVP murmur. In aortic stenosis, you have a crescendo-decrescendo murmur. Right? So these are some systolic murmurs. Okay. So what happens to the next one? What are the diastolic murmurs? This phonocardiogram is commonly asked in one-liners, right? As one-liners. So what about the diastolic murmurs? What are the diastolic murmurs that we are aware of? First is aortic regurgitation. In this, you have an early diastolic murmur, right? You have an early diastolic murmur. In aortic regurgitation, you have an early diastolic murmur, which is soft blowing, right? And then in mitral stenosis, you have an opening snap followed by a late diastolic murmur, right? Opening snap followed by a late diastolic murmur. Okay, so you have an opening snap followed by a late diastolic murmur. This is what you find in mitral stenosis. So where will you have a continuous murmur? Continuous murmur is seen in PDA, patent ductus arteriosus. Continuous murmur is seen in PDA, right? So you've seen the systolic murmurs and how the murmurs present, as well as the systolic, diastolic, and the continuous murmurs. Okay, so the answer to this question will be aortic stenosis. So next, moving on. On performing a pulmonary function test, the following graph is obtained. What does it characterize? Is it a restrictive lung disease? Is it an obstructive lung disease? A normal lung function is depicted, or is it a patient with an interstitial lung disease? Yes. So in these questions, what you can see, this interstitial lung disease is commonly a restrictive lung disease. So you can probably rule out those two options. So the option comes between whether it is an obstructive lung disease or is it a normal lung function. What is depicted here? Okay, so can anyone tell me what is the answer for this question? Is it an obstructive lung disease or is it a normal lung function? Yes, is it an obstructive lung disease or is it an normal lung function? What is it? Yeah, so the answer for this will be, so what happens, how will you do this? How is this test actually performed? So the patient is asked to take in a deep breath and forcefully expirate. Okay, so there's a deep inhalation and a deep expiration, and it should be done forcefully. So at that time, they will actually record the graph. Okay, so the gray one that you see is actually a normal tracing, right? The gray one that you see is actually a normal tracing. This one is actually a normal tracing. Okay, so this is a normal tracing. So what happens in these patients? Why do you have this concavity? So because of an obstructive disorder, the expiration is not proper, right? Because of this obstructive disorder, the expiration is affected. So that's why we have this concave thing. This concavity is because of an obstructive lesion. So when you have a concavity, it means that there is an obstructive lung disease. Obstructive lung disease. Obstructive lung disease. So what happens in this? The FEV1 is reduced. FEV1 is reduced, but the total lung capacity will be increased. Say like in emphysema, the total lung capacity will be increased, but the FEV1 will be reduced. So this is an obstructive lung disease pattern. Okay, so what happens in restrictive disorder? This will be shifted to the left. Okay, this graph will be shifted to the left because there is a restriction. Inhalation is also a problem, expiration is also a problem. So the shift of curve to the left will be found in restrictive lung disease, right? It will be found in restrictive lung disease. Okay, in this what happens here again, the FEV1 will be reduced and the total lung capacity will also be reduced. The total lung capacity will also be reduced. So here I want to ask you one question. What are the methods to find out the residual volume? What are the methods by which the residual volume can be found out? What are the tests which we do to find out the residual volume? Again, this is an MCQ. So what are the tests? One, I can tell you, nitrogen washout test, right? Nitrogen washout test. So can you tell me any other two residual volume measuring tests? Yeah. So the second one will be, and the most important one, which will be body plethysmography, right? Body plethysmography. And the third one will be helium dilution test, right? Helium dilution test. Okay, helium dilution test. So I have covered quite a few MCQs here. So what happens when there is an obstructive lung disease? What happens when there is a restrictive lung disease? And what are the tests to find out the residual volume, to measure the residual volume? Out of this, the best one is body plethysmography, right? Out of this, the best one will be body plethysmography. Okay. Yeah. So let's move on to the most important topic, which is ABG, which is frequently asked. Every year you have at least one question based on ABG, right? Yes. So coming on to ABG. The ABG analysis in a patient are as follows. The pH is 7.3, bicarb is 10, PCO2 is 30. What is the mechanism for the secondary disorder? So what is the mechanism for the secondary disorder? We have taken a previous class entirely on ABG discussion. So I would like all of you to go back there if you have any doubts in it. So you can just message me also anytime. I will be able to answer the doubts for you. So we first have to find out what the primary disorder is, then find out the secondary disorder and find out why it has happened. Right. So let's find out the primary disorder. pH is 7.3, which is slightly less, and the bicarbonate is 10, right, which is also less. So this is metabolic acidosis. Metabolic acidosis, this is the primary disorder. So what happens when there is a metabolic acidosis? The body has to compensate. Okay, so how do we find the compensated carbon dioxide? We have a basic formula, which is an EC1 shortcut. So bicarbonate plus 15. So that will be the expected carbon dioxide, expected PCO2, right? So expected PCO2 in this case will be 10 plus 15, which is 25. But here it is 30, right? Here it is 30. But here it is 30. So what does this mean? The fall in the carbon dioxide is less than it is expected. So it should have fallen to 25. So when there is a metabolic acidosis, the body should have reacted and decreased the carbon dioxide to 25. But the body has not done it fully. It has not been able to do it. Right? It has brought it down only to 30. From 40, it has come down to 30. So what happens in this patient? There is a respiratory acidosis. Okay, what happens in this patient? There is a respiratory acidosis. Right? The fall is not as much as expected. So in this patient, there is a respiratory acidosis. How could this have happened? This is because the carbon dioxide washout is not that much. Okay? The carbon dioxide washout is not effective. So this is because the hypoventilation has caused a decreased carbon dioxide washout. There is not enough ventilation to cause a carbon dioxide washout to increase. There is a hypoventilation which has caused a decreased carbon dioxide washout. So that is the mechanism for the secondary disorder. Okay? So there's one more question that I want to ask you. What is the test that you perform before doing an ABG? Before performing an ABG on a patient in the radial vessels, radial artery, what is the test that you should be performing on the patient, which is very, very important. Otherwise, the hand can become gangrenous. Okay, it is to test the patency of the ulnar vessels and the palmar arch. So, what is the vessel which we will be testing? What is that test? It is called Allen's test. Okay, this is again an MCQ, Allen's test. Right? This is again an MCQ. Yes. So, just a small word about the ABG. What are the three buffers that are very important? What are the buffers which are very important? What is the first buffer which acts in seconds? Which acts within seconds is the blood buffers. Yes, these are the blood buffers which act immediately. What are the second line buffers which act within minutes? So, a patient is having a metabolic acidosis, the patient will start breathing. So that is hyperventilating. What is this? This is called respiratory buffer, right? This is called a respiratory buffer, right? This is called a respiratory buffer. What is the third buffer which acts within hours to days, which takes hours to days to act? And it is a very efficient one. This is the renal buffer, right? It is the renal buffer. The renal mechanisms, the buffer is a very, very important one. And it takes hours to days for it to act, but it is a very effective buffer. Right? So these are the buffers. So some buffers that we have known, the Allen's test, and how to find out the expected compensation and how to find the primary and the secondary disorders is what we have learned from this question. Okay. So another image-based question. So 55-year-old male was presented with tachypnea and mental confusion and was brought by her husband to the emergency. Okay. And her blood sugar is 350. So patient having tachypnea and mental confusion. She is brought by her husband. Her blood sugar is 350. The following is her ABG. What is the primary metabolic abnormality in this patient? What is the primary metabolic abnormality in this patient? So let us write down the values. You can see this ABG here. So let us write it down again for easy calculation. So pH is 7.25, right? Then bicarb is, you can say 14.9. We'll have it as 15, right? And the PCO2 is 35.3, right? PCO2 is 35.3. And the oxygen saturation is around 77. Okay. So what is this patient? So this pH is also less, bicarb is also less. So the primary metabolic abnormality is metabolic acidosis. Right? Metabolic acidosis. So immediately as soon as you see the patient is having metabolic acidosis, what should you do immediately? You have to find out whether the patient is having a high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So we now check the anion gap. Anion gap is sodium. So what is the sodium? We have the sodium 140 minus bicarbonate plus chloride. So bicarbonate is 15 plus chloride. So 140 minus 122, right? It is 18. So the patient is having a high anion gap metabolic acidosis. So the patient is having a high anion gap metabolic acidosis. So after this, what do we find? We have to find out whether the compensation is adequate or not. So I told you expected PCO2 should be equal to bicarbonate plus 15. So it should be 30. But in this condition, it is 35. Okay, in this condition, it is 35. So what happens? You have an expected, you have a other metabolic abnormality along with it, which is respiratory acidosis, right? Respiratory acidosis. You have high anion gap metabolic acidosis, and you have a respiratory acidosis also. So we have found out two disorders. We need to find out whether a third disorder also exists or not. So how do we do that? We find the delta ratio and the delta gap, right? First, let us find the delta anion gap, which is, we can say it is minus 6. That is 18 minus 14 minus, you can say it, yeah, 12 minus, you can have it as 12. 12 minus 18, that will be minus 6. So delta anion gap is minus 6. And the delta bicarbonate will be 24 minus 15, which will be 9. Right? So what is the delta ratio? Delta ratio will be 6 by 9, which is equal to 0.6. So what does it mean if it is a more than 0.6? It means that there is a high anion gap plus the normal anion gap metabolic acidosis. You have a high anion gap plus a normal anion gap metabolic acidosis. So when the patient is coming with this kind of presentation, so why do you think there could be an anion gap which is normal also? That could be because of the chloride or because of vomiting, right? So the patient could be having a high anion gap acidosis along with a normal anion gap acidosis. Then how do you find whether metabolic alkalosis is there or not? For that, you need to find out the delta gap. Delta gap will be delta anion gap minus delta bicarbonate gap, which will be minus 15. So in this patient, you have a metabolic alkalosis also. Metabolic alkalosis also. So you have so many metabolic disorders in this patient, right? Yes. So the question is the primary metabolic abnormality. So, but I have elaborated to you, how do we find out the other abnormalities also? So initially you have to see the pH. The first step is the pH. Find out the primary disorder. If it's a metabolic acidosis, find out whether it's a high anion gap or a normal anion gap, and then see whether the compensation is adequate. If not, if there is a third disorder is also existing, that you have to find out with the delta ratio and the delta gap. Okay. So this patient is having a primary metabolic acidosis, right? Yes. So the patient is having a primary metabolic acidosis. Okay. So next question. A diabetic woman is admitted with complaints of vomiting. She gives history of consuming food from outside. On evaluation, her BP was 90 by 60 millimeters mercury. Her ABG report shows the following findings. What are the cause of her ABG finding? Okay. So in this patient, you can see that her pH is, 7.52. So what does the 7.52 mean? There is an alkalosis, right? We need to find out whether it's a respiratory alkalosis or a metabolic alkalosis. So the bicarbonate is high. So it means that there is a metabolic alkalosis. And there's a metabolic alkalosis in this patient. Okay. So metabolic alkalosis in this patient. So what do? We have to find out the expected PCO2. So bicarbonate plus 15. So it should be 45. Right? But this patient is having a PCO2 of 20 only. So this patient is having a respiratory alkalosis also. Right? This patient is having a respiratory alkalosis also. Right? I want some more answers in the chat box. You have respiratory alkalosis also in this patient. Right? So metabolic alkalosis and the respiratory alkalosis. So why do you think the patient could be having a metabolic alkalosis? That is because of volume depletion. Right? Persistent vomiting. So one more thing that you should be noting is the patient is having a BP of only 90/60, which means her volume is drastically depleted. And one more other important finding, which will be a clue for this, will be the chloride level. You can see that there is severe hypochloremia. That is because of loss of chloride in the HCl in the vomiting. So because of that, the chloride levels in the body have gone down drastically. That is why this patient is having a metabolic alkalosis. This is a persistent vomiting, right? So the answer is because of persistent vomiting, the patient is having this kind of ABG findings. Okay? Yes. Yes. So moving on from the ABG to other questions. So which of the following is the diagnosis based on the X-ray? Is it an acute pulmonary edema? Is it a pulmonary embolism? Is it a chronic obstructive pulmonary disease? Or is it a lower respiratory tract infection? What is the finding on this X-ray? Okay, I can zoom the X-ray for you. I would like some of you to answer the question. What is the diagnosis based on the X-ray? Can any of you tell me? So I'll give you a few minutes, few seconds for all of you to answer. You can try, it can be wrong. So I'll give you the options once again. Is it acute pulmonary edema? Is it a pulmonary embolism? Is it a COPD or a lower respiratory tract infection? Which of these is it? Yes? Okay. So I would like all of you to notice very keenly this X-ray. When we zoom, you can see that there is a there's a oligemia in this location, right? There is an oligemia in this location, right? The blood flow is reduced in this location. So this is called focal oligemia. You can see here there is a focal oligemia. Focal oligemia. So what is this focal oligemia? What do we mean by it? The blood flow in that region is reduced. So why does this happen? Because there is a abrupt cutoff because of the pulmonary artery flow. Okay, there is an abrupt cutoff. So there is a focal oligemia in this location. So this focal oligemia, what is it a sign of? It is a sign of pulmonary embolism. Okay. Okay, there is a thrombus which is occluding the pulmonary area in that region, because of which the blood flow is not flowing past that, and there is a focal oligemia. Okay, so this sign, what is it called? It is called the Westermarck sign. Westermarck sign. So all of you are aware of the different signs in the pulmonary embolism, isn't it? What are all the different signs, different radiological signs that we find out in pulmonary embolism? We're going to list it, which are potentially MCQs, each one separately. Okay. So the Westermarck sign, this is a focal oligemia in that location because of the abrupt cutoff of the pulmonary artery. Okay. So what are the other ones we will discuss? So basically, why does this pulmonary embolism happen? The embolism happens because of the hypercoagulability. It can be because of three things. The Virchow's triad. So Virchow's triad. So they have asked so many questions on this Virchow's triad. They have given 4 options and say which one of these is not a factor which actually causes this embolism to happen. Okay, which of the factor which is not implicated in this pathogenesis. So Virchow's triad we should be knowing. We know this from pathology also. So what are the components of this Virchow's triad? You have the endothelial damage, right? Endothelial damage, stagnation of blood flow, and hypercoagulable state. So in the questions, what will they describe? They will describe a patient with a long haul flight. They can describe a patient who has just undergone surgery and on immobilization, right? They can also mention hypercoagulable states like a patient with a factor V latent mutation. They may say OCP use. All these are clues to find out that this is leading something towards an embolism or a pulmonary thromboembolism or a DVT, right? This is what it is showing you towards. So it can be either an endothelial damage, it can be a stagnation of blood or a hypercoagulable state. As I told you, the questions can describe all these things in the, see, all these are clues in the question. So we have to pick up the clues and find out the answer, isn't it? So these are the findings. So what are the hypercoagulable states? Very commonly, it can be a factor V latent mutation or protein C proteinase deficiency. All these things are the hypercoagulable state. OCP is a very, very important thing that you need to keep in mind, right? It is a very, very important thing. Even polycythemia vera is also hypercoagulable state, right? So all these things you need to keep in mind. These will be clues in the question, right? So what happens when there is a pulmonary embolism? What happens is the pulmonary embolus is blocking the blood supply. So because of that, the pulmonary arterial pressure will increase. So there is a pulmonary arterial hypertension. This is reflected onto the right ventricle, later onto the right atrium. So what happens? There is a right ventricular failure. Right ventricular failure happens. So what are the findings of the right ventricular failure? You will have pedal edema, then hepatomegaly, tender hepatomegaly. Your JVP will be elevated. You will have ascites. Right. All these things are findings. Then along with JVP, you will have a Kussmaul sign, right? Kussmaul sign. This is also again another MCQ. That is the JVP increasing on inspiration. The JVP increasing on inspiration. So that is called Kussmaul sign. Right? Kussmaul sign is again another MCQ. JVP increasing on inspiration, which is found in right ventricular failure. This is called Kussmaul sign. Right? Okay. So because of this right ventricular failure, what happens? This pressure is transmitted to the left side because of the septal deviation. So after that, you will have a left ventricular failure. Okay. And before that, what happens? The cardiac output decreases. The stroke volume decreases. The stroke volume and the cardiac output decreases. Because of that, the BP will reduce. Okay. The patient will be in hypotension. So this is the acute hemodynamically unstable condition when the patient with a pulmonary embolism comes to you with an hypotensive state. This is the mechanism of that. Okay. So what are the X-ray findings that we will see in this patient? So first one we discussed that is Westermarck sign, which is focal oligemia. Right. So what can happen? The other thing, because of the loss of blood supply in that region, there can be an infarction. Right? There can be an infarction. So triangular shaped opacity will be there, which is called a Hampton's hump. Right? This is called a Hampton hump because of infarction. This is a pulmonary infarction. Right? This is called a Hampton's hump, which is a pulmonary infarction. Okay. So what is the next one which you will find? The pulmonary artery will be enlarged. But the pulmonary artery will be enlarged and you can find the curve on the X-ray. This is called a Fleischner sign. Fleischner sign. And one more thing is the descending pulmonary artery can also be enlarged. So this is called a Pala sign. This is called a Pala sign. So these are all named things that you must remember. The Westermarck sign, Hampton hump sign, Fleischner sign, and Pala sign. Okay, the most commonly asked ones are the Westermarck sign and the Hampton's hump. Hampton's hump is basically a pulmonary infarct. It will be a triangular wedge-shape opacity. Okay, mostly in the peripheries. Okay, yes. So this is the radiological findings. But what is a gold standard test for finding out? This is all on X-ray. So what is a gold standard test for finding out the pulmonary embolism? It is the pulmonary angiography. Pulmonary angiography, right? And what is the standard ECG finding? The ECG can show S1, Q3, T3 pattern. So S1, Q3, T3 pattern. So this is the ECG finding. So the questions can be phrased differently. They can say a patient who with a prolonged OCP use has come to you with hypotension and difficulty in breathing, sudden onset difficulty in breathing, and the ECG is showing S1, Q3, T3, and the X-ray shows an enlarged pulmonary artery. So what does this mean? The patient is having a pulmonary embolism, right? The gold standard test is pulmonary angiography and the ECG will show S1, Q3, T3, right? So what is the treatment? Anticoagulation and thrombolysis. Thrombolysis initially followed by anticoagulation, right? You thrombolyze the patient initially and then you put the patient on anticoagulation, right? One more thing which I want to tell you, which is an important one, which is the Wells score. Right? This is again another MCQ which is commonly asked. What is the Wells score? It helps in predicting the pulmonary embolism. So I have it written down for you. What is so the answer for this question will be pulmonary embolism. It's not an acute pulmonary edema. You don't see the battering appearance, and there is not a chronic obstructive pulmonary disease because the lungs are not that much hyperinflated, and there is no evidence of any consolidation. So it's not a lower respiratory infection, right? So this is the Wells score. So these are based on when the patient is having DVT. What is the risk of developing a pulmonary embolism? Okay, so clinical signs and symptoms of DVT, the points are 3. P is the most likely diagnosis. Tachycardia, immobilization or surgery, prior DVT, the patient is presenting with hemoptysis, and if there is an active malignancy. Like I told you, all these are risk factors for developing an embolism, pulmonary embolism. So based on this, we can find out what is the probability of the patient developing a pulmonary embolism. And this is called a Wells score. It is commonly asked in the MCQs very frequently. Okay, yes. So let us now move on to the next question. The CSF specimen of a patient is shown below along with a microscopy. The report shows mononuclear cytosis, elevated proteins, and low sugars. Which of the following is the likely etiology? So this is the CSF microscopy and this is the CSF, standing picture. So what do you see in this? Dr. Venkatesh, are you there? You can answer the questions. So what is this? What do you see in this? This is a very characteristic finding. I'm sure all of you are aware and thorough of it by now. It is a cobweb coagulum, right? Cobweb coagulum. Okay. So it's a cobweb coagulum. And what happens in this? Why does this happen? This is because of the excessive protein. This is because of the excessive protein. And what you will find in the microscope, you will have lymphocytes, right? It's a lymphocyte predominant inflammation. So lymphocytes will be present. So what do we find? This is because of, where you find a cobweb coagulum? This is in tuberculous meningitis, right? It is in tuberculous meningitis. So let us now discuss just the, first of all, when you do an LP, what are the structures which pierce? This is very commonly asked and we commonly get it wrong. It is an anatomy question also, but you can discuss it under medicine as well. So it's an overlap question. So what are the layers pierced? Can any of you tell me the layers pierced in order? You can enumerate it in the chat box. Yeah. So the first one, it will be the skin, right? After that, it will be the subcutaneous tissue. Skin and subcutaneous tissue. After this, a couple of ligaments and then the dura mater comes, right? What are the ligaments which are pierced? First is the supraspinous ligament, right? First is the supraspinous ligament. The next one will be the interspinous ligament. Supraspinous ligament and the interspinous ligament. So once these two ligaments are over, you have the ligamentum flavum. These all of us will remember, ligamentum flavum. And the final one will be the dura mater. After which you have the CSF, right? After which you have the CSF. So the layers pierced are skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and then you get the CSF, right? So this is the order in piercing. So what is the most common complication? You will have a headache. Most common complication will be a headache. Spinal headache, yeah, headache. So how do you treat this headache? You hydrate the patient, you ensure good oral intake, you ask the patient to lie down flat without any pillow, okay? You hydrate the patient, then you give a lot of IV fluids, then you give caffeine, codeine. If none of this works, you give a low volume blood patch, right? Refractory spinal headache, what is the treatment? Low volume blood patch. That is the treatment, yeah, right? So low volume blood patch is the treatment for refractory spinal headache. So this is something short about LP, which is commonly asked. These are commonly asked questions, right? Again, this is an MCQ. So coming on to the meningitis findings. So we'll now discuss what are the meningitis findings based on the gross appearance, then proteins, cells, and the sugars. So what are we going to discuss about TB, bacterial meningitis, viral, right? These three are the most common ones, right? So what happens in bacterial, first we'll describe, it will be a very cloudy fluid, right? It will be a cloudy fluid and the cells will be increased, and this is polymorphonuclear cells. These are neutrophils, right? These are basically neutrophils. And the sugars will be reduced because of the multiplication of the bacteria, which requires sugar, okay? Which requires glucose. So the sugars will be drastically reduced in these patients. What happens in tuberculous meningitis? The fluid will be clear, but it can be sort of slightly yellow color, like slight yellow color, a straw colored fluid will be there. Again, bacterial, what will be the proteins? It will be slightly elevated. But in tuberculous, the proteins will be very, very high. The tuberculous thing, it will be very, very high. The cells are also elevated, but it will be mainly a lymphocyte predominant one. It will be mainly a lymphocyte predominant one. And the sugars will be, it can be either reduced or normal or reduced, right? Yes. And what about viral? Again, it will be a clear fluid. It will not be cloudy. The proteins are again elevated. The cells will be increased. It is mainly lymphocyte predominant, and the sugars will be normal or decreased, right? It is most commonly decreased in tuberculous, whereas it will be normal, most of the times normal in viral meningitis. Okay. Yes. So these are the findings. I want to ask you one thing. So where will you find a protein high? Proteins will be high in the CSF, but the cells will be very less. In which condition do you find this CSF finding? The proteins will be elevated, but the cells will be very less. Where do you find this finding? Can any of you tell me? So as you can see here, whenever the proteins are elevated, the cells are also increased. But in which condition will the proteins be elevated, but the cells are reduced? This is in which condition? It is characteristically seen in GBS, Guillain-Barré syndrome. which is albuminocytological dissociation, right? Albuminocytological dissociation, right? Yes. Albuminocytological dissociation. So the next one is, what are the contraindications to do LP? Basically, it is an increased intracranial tension, a low, a local skin infection or an abscess, a spinal deformity. All these things are contraindications for performing a lumbar puncture, right? Yes. So next, move on to the next question. A 50-year-old patient, a known case of hypertension, presents with sudden onset breathlessness. Just X-ray shown below. How will you manage the patient? This is very easy for you. Yes, this is a bat wing appearance. Right, let me clear it so that you can see it clearly. I'll enlarge it for you. Sorry. So this is a bat wing appearance. So bat wing appearance is seen in pulmonary edema. Right, we'll go fast. It's seen in pulmonary edema. I'm sure all of you are already thorough with this. This is a very basic question, very easy one. But because I wanted to discuss lateral items, I put this question here. So this is very commonly seen in pulmonary edema. Right? Yes. So in pulmonary edema, what happens? When does the patient present with pulmonary edema? When there is an acute left ventricular problem, right? When there is an accelerated hypertension, when there is a malignant hypertension, when there is a hypertensive emergency, hypertensive urgency, the patient is having a pulmonary edema, right? So what are the findings in this pulmonary edema? The patient will have breathing difficulty, he will have cough, he will not be able to lie down flat, there will be orthopnea, all these findings will be there, right? These are all characteristic findings of LVF. Like I told you, right ventricular failure earlier, you will have pedal edema, ascites, tender hepatomegaly, JVP will be elevated. All these findings are for right ventricular failure. Whereas for left ventricular failure, you have breathing difficulty, right? Breathing difficulty will be there. You will not be able to lie down flat. Orthopnea, paroxysmal nocturnal dyspnea. All these things are finding of left ventricular failure. You'll have crepitations on the lung basis, right? So these are all findings of left ventricular failure. So what happens in this patient? What are the other findings that you can find out on the X-ray? So one is this bat wing appearance, right? One is bat wing appearance. Next is the curly B lines. What are these curly B lines? These are lines which are perpendicular to the pleural surface, right? These are perpendicular to the pleural surface. Curly B lines. You can also see the costophrenic angle blunting. If this patient is having acute pulmonary edema, once it becomes worsens, here you can see this costophrenic angle, CP angle blunting will be there because of fluid accumulation, fluid overload. So the patient will be having a CP angle blunting. And the patient can also have a cardiomegaly, right? Cardiomegaly will be there. How do you find out this cardiomegaly? This will be based on the CT ratio, cardiothoracic ratio. So these are all the common findings of pulmonary edema in a patient with pulmonary edema. Okay. So basically you will have bat wing appearance, you will have curly B lines, and you will have CP angle blunting. Cardiomegaly will be there, right? Yes. So what happens? How will you treat this patient? You have to give Lasix. Yes, you have to give Lasix. You have to give oxygen if needed. You have to give a positive pressure ventilation. Right? You have to give a positive pressure ventilation. Okay. So the patient is presenting with acute pulmonary edema. Apart from giving Lasix, you should also be giving the patient morphine if needed. Right? You should also be giving the patient morphine so that the cardiac oxygen demand comes down. Okay, and the patient is able to breathe better, little better. Okay. And for the hypertension, what should you do? You should give the patient nitroglycerin. Right? You should be giving the patient nitroglycerin. So once we come to this point, we shall discuss what is hypertensive urgency and hypertensive emergency. So all of you know, in emergency, you have a target organ damage, right? Target organ damage will be there. In this, it will not be there, right? The BP values, they have mentioned BP more than 220 by 130, but these are not absolute values. Just because if the patient is having a BP of 180 by 100 or 180 by 110 and the patient is coming with a stroke, that does not mean that the patient is not having a hypertensive emergency. So we should not take the very critical values under the consideration. It should be based on whether the target organ damage is there or not. Okay, so hypertensive urgency, hypertensive emergency. What is malignant hypertension? In malignant hypertension, you have retinal hemorrhages. You can have a MAHA, which is a microangiopathic hemolytic anemia. You can have a bleed in the brain, intracerebral bleed in the brain, right? All of these things you can have, right? So these are all findings of malignant hypertension. Malignant hypertension. Okay. Yes. So based on how will you treat these patients? How will you treat these patients? Based on the ACVD. For malignant hypertension, obviously you have to give the antihypertensives. You should give the antihypertensives. Yes, based on the you should give the antihypertensives. Yes. So for other patients who are presenting to you with BP, elevated BP, how will you treat the patient is based on the ASCVD risk score. So you should be giving based on the ASCVD risk score. Okay. So when the BP is elevated in a patient with, if the BP is more than 130 by 80, and if the ASCVD risk is increased, then you have to treat the patient. Okay. If the BP is more than 140 by 90, if the risk is not increased also, you should be treating the patient. Right? The BP is more than 140/90, you should treat the patient. If the age is more than 65 years, and if they have the BP of more than 130/80 or 140/90, then you should be treating the patient. So these are all the conditions where you should be treating the patient. But before going on to giving medications, what should you say that tell the patient? You should advise lifestyle modifications. You should advise lifestyle modifications as well as should give a DASH diet. Right? You should give a DASH diet. Lifestyle modifications as well as a DASH diet. Okay? This is very, very important. So what are the drugs that you use? Basically, you have AC inhibitors or ARBs, which are basically the first line now. Then you can give thiazides. But before giving thiazides, you should try calcium channel blockers. Okay, AC inhibitors or ARBs, calcium channel blockers and thiazides. Calcium channel blockers and thiazides. Right? So when will you give the patient beta blockers? When they're having an angina or congestive heart failure. When they're having an angina or a congestive heart failure, then that time you should be giving the patient beta blockers. Right? Yes. Okay. So we have discussed quite a few questions here. Drugs to treat hypertension. When will you treat hypertension? Then what is hypertensive urgency, emergency, malignant hypertension, and pulmonary edema treatment? What are the radiological findings? So all these things we have discussed. So now, what is the CT finding in this patient? Okay. What is the CT finding in this patient? Yeah. So this is a consolidation with an air bronchogram. Consolidation plus air bronchogram. Right? Consolidation plus air bronchogram. Here you can see these are the air bronchograms. Okay. These are the air bronchograms in the patient. So this is a consolidation plus air bronchogram. So there's one point which I wanted to discuss with you, which is curve 65 score. All of you know, C is for confusion. U use for urea or bun more than 19, respiratory rate more than 30, and the B will be the BP. So if the systolic is less than 90 or the diastolic is less than 60, then you will add points. So based on that, you will decide whether the patient has to be treated as an OP setting or ICU or a ward admission. Right? So based on that, the curve 65 score, you decide that. Right? Okay. Let's move on to the next question. So a young man came to the medical OPD with complaints of early morning backache and stiffness, which improves on exercise and persistent red eyes are there. On examination, lung expansion was less than 3 centimeters. So what is the X-ray showing below? What are the answers? Is it ankylosing spondylitis? Is it a Paget's disease, osteoporosis, or heel tuberculosis? So what is the diagnosis in this patient? Right? Okay. So I think you have got some clues from the question. You have a young man, early morning backache and stiffness, which is improving on exercise and the persistent red eyes. Lung expansion they mentioned is less than 3 centimeters. So by now you should have guessed what it is. The answer is ankylosing spondylitis, right? The answer is ankylosing spondylitis. But some more MCQ points. What is the predisposition? HLA-B27 is a predisposition, right? What is ankylosing spondylitis? It is basically a spondyloarthropathy. Spondyloarthropathy. It's a spondyloarthropathy. It is central predominant or axial predominant. Axial skeleton is affected. So it is an axial skeleton predominant one. Right. It is most common in males. It is most common in males. Our question is also describing a male. Right. Our question is also describing a male. It is more common in HLA-B27. Okay. So what is the finding? Earliest finding you have? Earliest finding will be sacroiliitis. What is it? It is sacroiliitis. The earliest finding will be sacroiliitis. What is the red eyes that they are mentioning? That is extraocular manifestation will be uveitis. right? The extraocular manifestation will be uveitis. Sometimes the patient will be presenting to the ophthalmologist first with uveitis, and then later on when they do the HLA-B27, they will know that the patient is at risk for ankylosing spondylitis, and they will keep the patient under constant monitoring. Okay, so the red eyes is uveitis. Okay, and lungs you will have a upper lobe NSIP, non-specific interstitial pneumonia. These are the two important extra axial findings. What are the apart from the rheumatological findings, what you will have, that is the uveitis and the upper lobe non-specific interstitial pneumonia. Right? Yes. So what are the other things? Cardiac findings, aortic regurgitation. This we have discussed very much in detail in our discussion on ankylosing spondylitis previous lectures. So you can just go back to that and revise it once again. The cardiac manifestation most commonly will be aortic regurgitation. Okay. And like we all know, most of the autoimmune diseases, when we talk about an renal manifestation, it will be an IgA nephropathy. Okay. These are the first extra-articular manifestations that you must remember. Extra-articular manifestations that you must remember. Okay. So what are the tests that we do in this patient? Schober's test. How do we do? We take the posterior leg spine, posterior leg superior spine. From that we measure 10 centimeters, make a mark. From that below 5 centimeters, you make a mark, and you ask the patient to bend forward without bending the knees. So what happens? The distance should be increased. If it is not increasing and if it is less than 15 centimeters, it means that the patient is having an ankylosing spondylitis. So what are the X-ray findings in this patient? I'll tell you the most important ones. So the first one that we have seen, this will be a dagger spine. Dagger spine. So this is mainly because of the calcification of the interspinous ligaments. And the calcification of the interspinous ligaments will be there, and the joint capsule calcifications will be there. So this is a dagger spine. Okay. The next one will be railroad sign, right? Railroad spine. In this, what happens? You will have this calcification. Interspine. This is the joint capsule or the interspinous ligament which gets calcified. This is the railroad spine. And the third one will be a trolley track spine. Trolley track spine, in which you will have, sorry, one second. In this, you will have both the dagger spine as well as the railroad spine. You will have both the dagger spine as well as the railroad spine. This is called a trolley track spine, right? And the other one you commonly know, it is called bamboo spine. It is also called bamboo spine. Bamboo spine is important. Then there are erosions which you can see, which are called raminus erosions. Raminus erosions, which you can see on the X-ray. Okay, these are all important radiological findings. This is very, very important. What is the treatment for these patients? We saw in the question that they improve with exercise. So physiotherapy is a must. Physiotherapy is a must. You have to treat the patient with NSAIDs or TNF-alpha blockers. TNF-alpha blockers. So physiotherapy is a must for this patient. You should ask them to keep constantly moving so that they can, keep the mobility. The mobility as the disease progresses, it will keep restricting. So you need to keep the patient on continuous physiotherapy. Right? Okay. So identify the disease based on the clinical sign. So identify the disease based on the clinical sign. We are coming to the end. Okay. Identify the disease based on the clinical sign. This is exophthalmos or lid lag sign. Exophthalmos or lid lag sign. Lid lag. Right? This is seen in Graves' disease. All of us know it is a autoimmune disease of the thyroid with antibodies. Okay, antibodies, thyroid stimulating antibodies will be there. Thyroid stimulating antibodies will be there. Anti-TPO antibodies will be there. Anti-thyroid peroxidase antibodies will be there in these patients. So what are the other hyperthyroidism features that you will have? The patient will be very restless. They will be having heat intolerance. The patient will be having tachycardia, palpitations most of the time. They'll be very hyperactive and very irritable patients. Okay, so these are all the findings of hyperthyroidism. So what happens? Why do we have this Graves ophthalmopathy? Why do we have this? This is because of deposition of the glycosaminoglycans in the connective tissue or the musculature, extraocular muscles. So because the extraocular muscles, the connective tissue content is increased, so the eye tends to be pushed out. Okay, the glycosaminoglycans will be increased. Okay, the glycosaminoglycans will be increased in the surrounding connective tissue as well as in the extraocular muscles. There will be a lymphocytic infiltration. So because of that, the eye is popped out. Okay, this is Graves ophthalmopathy. In this, what will happen? The free T3 and T4 will be elevated and the TSH will be very much suppressed. Okay, T3 and T4 will be elevated and the TSH will be suppressed. So in this, what will happen? The radioiodine uptake will be increased. Because of the increased activity, the radioiodine uptake will be increased. What are the conditions? Again, this is an MCQ. Radioiodine uptake will be decreased. The main one will be Hashimoto's thyroiditis. Okay, radioiodine uptake will be decreased in Hashimoto's thyroiditis. Right? Hashimoto's thyroiditis. The other one will be subacute thyroiditis. Subacute thyroiditis. Okay, so Hashimoto's thyroiditis and subacute thyroiditis. So these are the two findings in which the radioiodine uptake will be low. So how do you treat these patients with Graves' ophthalmopathy and Graves' disease? How do you treat them? The main ideal one will be radioiodine uptake. Radioiodine given. Okay, you give radioactive iodine. That will be the ideal thing. But there are few patients in whom you cannot give, like in pregnancy. Okay. Now comes another important MCQ. How will you treat the patients with first trimester and in second trimester, after the second trimester? How will you treat these patients? So what is the drug of choice in first trimester? Propyl thiouracil is effective in these patients and it is safe to be given in the first trimester. Whereas in the patients in second trimester, you can give carbimazole, right? This is again very important, very frequently asked MCQ. If you have to remember, in first trimester, it is propyl thiouracil. Second trimester, it is carbimazole. Second trimester, it is carbimazole. Okay? Yes. Let's move on to the next question. So this is a very scary image. And I think it should be a very good spotter for all of you to find out. So it's a 50-year-old HIV patient who presented with a painful lesion shown in the image. What is the most likely diagnosis? Here you can see this is violet colored, right? It is violaceous. So when you say violaceous, the most common will be Kaposi sarcoma, right? So the answer will be Kaposi sarcoma. This is the answer. So this is the AIDS-defining malignancy, right? This is one of the AIDS-defining malignancy. AIDS-defining lesions. Okay. Among that, Kaposi sarcoma is very, very important. Okay. Kaposi sarcoma is very, very important. Kaposi sarcoma is very, very important. So a few words about Kaposi sarcoma. It is caused by HHV-8 infection. Okay. It is caused by human herpes virus 8 infection. And the site, oral is the most common. You can get it on the skin and the extremities also, obviously. But the oral is the most common. Oral will be the most common. Okay. And the AIDS-defining lesions, as I just mentioned you. First is Kaposi sarcoma. The second will be non-Hodgkin's lymphoma. The second will be non-Hodgkin's lymphoma and invasive cervical cancer. Invasive cervical cancer caused by HPV 16 and 18. HPV 16 and 18. So the AIDS-defining malignancies are basically Kaposi sarcoma, non-Hodgkin's lymphoma, invasive cervical cancer, HPV 16 and 18. Okay, so you need to remember the CD4 count and the infections which are most likely caused. So this is very, very commonly asked. You can remember this and it is quite easy to remember also. CD4 count, if it is less than 500, it is mostly tuberculous and it happens very easily. So tuberculous infection, they have a very high threshold for that, very low threshold for that. So if the CD4 count is less than 500, they develop tuberculous infection. If it is less than 200, then it is pneumocystis jirovecii pneumonia. And if the patient is having a CD4 count of less than 100, then it can be toxoplasmosis. And if the CD4 count is less than 50, you can have CMV retinitis. Okay, CMV retinitis. So these are the 4 important ones that you must remember. Less than 500 TB, less than 200 PCP pneumonia, then less than 100 toxoplasmosis. If it is less than 50, CMV retinitis. Okay. Yes. So what are the other one point I want to tell you? So there can be a trick question. They would say that a AIDS patient is coming with a pneumonia. HIV patient is coming with a pneumonia. Okay. And they mention some CD4 count. They say suppose CD4 count is less than, say suppose 150. It is less than 200. And they ask what is the most common organism. So we tend to answer this question as PCP pneumonia. But you must all remember that even though the patient is prone for PCP pneumonia, still the most common organism causing pneumonia in this HIV patient will be Streptococcus. Right? This is a very, very important point that you must remember. Streptococcus is the most common organism causing a pneumonia in a HIV patient. They are at an increased risk for PCP. I don't say that PCP will not come. Even if the CD4 count is less, PCP can come, but still the most common organism will be Streptococcus. Right? The most common organism will be Streptococcus. And in PCP pneumonia, what are the findings that you will have? You will have perihilar opacities. Right? Perihilar opacities will be there. Perihilar opacities will be there, and the treatment will be cotrimoxazole. Right? Cotrimoxazole. Right. So how do you have to treat the patient earlier? So once you treat the patient earlier, they have a good mortality benefit. AIDS patients, they have a good mortality benefit if you treat earlier. Okay. So there is one question again they will be asking. If a patient is having a TB and HIV, so how will you treat this patient? How will you treat this patient? So for this patient, you should start the ATT. ATT should be given first, followed by ART, antiretroviral therapy. This is because of a condition which can develop, which is called immune reconstitution inflammatory syndrome. Again, this is a very, very important, MCQ that they are commonly asked. This is very, very important, immune reconstitution inflammatory syndrome. If you give ART first before starting an ATT, then the patient will develop IRIS. So you should first start the patient on ATT and then you have to give ART. Okay, it's a very high yielding question. So I hope you all remember all of the points. Okay, yes. So 65-year-old chronic smoker came to the OP with complaints of upper chest discomfort and drooping of eyelids. He also complained of pain radiating to the upper arm and a tingling sensation in the 4th and 5th digits of his left hand. The X-ray is given below. Which of the following is the most likely diagnosis? It's a very straightforward question. So chronic smoker, there's a clue there. Upper chest discomfort, something causing the upper chest, that you have to see what is the finding there in the X-ray. Then drooping of eyelids. Then the bells must ring. So it could probably be Horner syndrome. Horner syndrome. Then you have pain radiating to the upper arm, C8 and T1, T2. T2 is affected. C8, T1 and T2 is affected. Okay. So where do you find all these things? This is most commonly given the age and the chronic smoker and the complaints that they have mentioned with the Horner syndrome, it is most likely to be a Pancoast tumor. Right? It is most likely to be a Pancoast tumor. It's not superior vena cava obstruction. They have not mentioned about the engorged veins. It's not an aspergilloma. They have not mentioned any kind of chronic cough or anything. And even if they had mentioned, it is not an immunocompromised state that they have mentioned. Yes, an upper lobe pneumonia, that is not very common, which will cause Horner syndrome. In upper lobe pneumonia, you don't get a Horner syndrome, right? So this is a Pancoast tumor, right? So what is the other name for a Pancoast tumor? It is a superior sulcus tumor, right? Pancoast tumor is a superior sulcus tumor. Yes, superior sulcus tumor. So the complications are, Horner syndrome are there. I already told you C8, T1, T2 nerve roots can be affected. So the stellate ganglion can also be affected, right? All this happens. So in this patients, what do you do? The clue will be with the chronic smoker. Okay, so this is the most common thing that they will ask. Pancoast tumor, what are the complications? Horner syndrome and nerve compression, C8, T1 and T2. What is the other name for it? Superior sulcus tumor. Okay, yes. So what is this finding? This is the last one. This is a hematology question which I wanted to put in. So this is basically a peripheral smear or a bone marrow finding. Bone marrow finding, you can say. So what is this? These are the OR rods. You can see this OR rod here and here. So where do you find OR rods? OR rods are found in AML. Right? AML. OR rods are found in AML. It is the most common leukemia in adults. Right? It is the most common leukemia in adults. What happens? You can have OR rods. There are multiple varieties that you have to remember, but I will tell you a few important points for AML that you should remember from the MCQ point of view. Okay, so what are the defects which are happening in this? What are the common defects? PML, RA. These are the mutations which are happening. Then you can have a translocation 821. Then you have one more translocation 1616. This 821 is more important. Then you have inversion 16, which is also very, very common. So these three things you must remember: PML, RARA, translocation 821, inversion 16. All these three are very, very important. Okay. So which is very commonly repeated in the exams. Okay. So what are the other findings that you will have in this patient? How do you diagnose this? You have to find OR rods. You will also have to find myeloblast. Myeloblast should be more than 20%. Myeloblast should be more than 20%. Okay. So in these patients, tumor lysis syndrome can happen very commonly. tumor lysis syndrome. What will happen? You will have an acute kidney injury. You have an acute kidney injury. Potassium will increase. Uric acid will increase. Hyperuricemia will be there. So that is tumor lysis syndrome. Right? Tumor lysis syndrome, AKI will be there. Potassium will increase, and there will be a hyperuricemia. Right? So some few points which you have to improve. You want to remember about the classification. I'll tell you AML M5. What should you remember about this? Gingival involvement will be there, right? If the question says the patient is having a gingival involvement and find out the type, then you have to say it is AML M5, right? AML M5. Then comes AML M3. In this, the translocation is 15-17. You have to important translocation 15-17. In these patients, they are at an increased risk of developing DIC. Gingival involvement in AML M5, in AML M3, which is translocation 15-17, there is an increased risk for developing DIC. Right? Then AML, next will be AML M7. This is more common in Down syndrome. This is more common in patients with Down syndrome. Right? And AML M6. AML M6. This is pure erythroid leukemia. So other things will all be related to the monocytes, myelocytes, all those things. But this alone that you have to remember, this is related to erythroid series, pure erythroid leukemia. Pure erythroid leukemia. So the important points, AML M5. AML M5 will be gingival involvement. AML M3, it is translocation 15-17. Their more risk of complication is DIC. AML M7 is Down syndrome. And AML M6 will be a pure erythroid leukemia. Okay. So you have learned so much about the I have basically concentrated on the image-based questions today. I hope it was very high yielding for you. I'm sure it will be high yielding. So you have to basically learn the concepts and the questions can be different. We all know the questions will not be verbatim from last year or the previous year before that, but you need to remember the concepts. So concepts are very, very important. I hope it was very useful for you. So we shall meet again tomorrow for the next session, which will be basically questions discussion. Okay. Thank you so much for joining in today.
Thank you so much, ma'am. We are eagerly waiting for the next session tomorrow.
Thank you.
We'll close this session. Thank you.